All right. Is this a break, or are we good to keep rolling?
I guess we can keep rolling and see why not.
Finding this helpful, whoever's on?
Big time.
Yeah, definitely. It's helpful to run through some questions. Absolutely. Maybe at the end, if there's a chance, if you could maybe just talk about just structure of the exam in general and just tips on like, because there's certain things in CBPS, right? Like make sure you click on imaging first, like that sort of stuff.
100%. 100%. I think let's we can if you want we can skip through and do that now.
Whatever you want, yeah.
It's up to you. Whatever you guys want. I mean, I can do that now if you want.
Sure. Yeah, sure. Why not?
Okay, let's do that. So, because I find the best way is to actually show you and go through examples. All right, so we're gonna let me share my screen. All right, so I have the ABFAS website has a practice case series, and I think it was 5 originally. Now they added maybe 2 more, but every case they give you 15 minutes to do. So timing is very important, and it's all about strategy. So one thing is you will not be judged or graded based on how much imaging you order. I'll repeat, you will not be graded based on how much imaging you order. You will not be graded based on a physical exam component that you pick to evaluate. For example, unless it's harmful. So if you have an infection case and you choose to check muscle strength, that's fine, even though they're not looking for that, even though that's not gonna give you any points. They're looking for certain things, key things in the physical exam. And this is the most difficult because you only have so much, right? That you only have 10 things to pick from here. Labs, you have 20. Imaging, you have plenty. I think they give you up to 5, maybe 10. Sometimes they give you 10. So imaging, typically I jump straight to, like you said, I read the paragraph, the presentation of the patient, and then I jump directly to imaging. That's the first thing I do, and I get every single imaging that I think I'll need, all the time, every time. X-rays, X-ray foot, X-ray ankle, bone scan, MRI, weight, white blood cell count, or white blood cell labels, or Certex scans, ultrasound, everything, chest X-ray. So you're not going to be graded based on the fact that you over-ordered, but you need to hit the right components, right? You need to hit the right components. So we'll go over, we'll do the first case, and then we'll go over the how they grade it and what they look for. So typically I jump straight, I'll read it, I'll jump, and you usually take me like 30 seconds to a minute, and I'll go straight to imaging. I'll get all the imaging that I think I'll need or may not need. then I'll go to labs. Then I go to physical exam. The imaging plus the labs plus the paragraph again will dictate what I do in the physical exam. Every time. I'll repeat. The imaging, the labs, and what I read here, all in combination, I usually jot down some things, that will determine what I do in the physical exam, because they're not going to need you to do every single thing on every exam, for every case. You still may want to do it, like palpate pulses. You want to do that with every, obviously with, it's just one thing, but it's 1 out of your 10. So, and you only have 10. That's what makes it difficult. That's what makes this difficult. But I can tell you with confidence that I've mentored many residents who've passed every single one of these on the first try. Because it's just a way that, even when I was a resident, I used to think, you want to order. I didn't know how to take this. Nobody ever taught me or explained to me that's how the exam worked. I guess I just got fortunate luck, I just got lucky, but that's how it works. You're not going to get points off by ordering a CT scan and an MRI and a bone scan. They'll just tell you it's not available. So what? Is that clear for everybody?
Yep.
All right, cool. Who's going to take this case? Who wants to rock it out, or should I do it?
Sure, I can do it. I'll do it.
It's the same. Where's Amin? He's on here. All right.
Yes, sir.
Well, are you sleeping or?
No, I'm here. I'm listening. I can do the next one if you want to do this one.
You'll do the next one. Okay, let's go. Ready? Yep. Focus. Go.
Okay. 43-year-old male presents post-operative shoe with complaint of painful swollen left fifth digit. He relates a history of stubbing his digit 2 weeks ago while in hospital being treated for sepsis, secondary sinusitis. He was discharged 10 days ago and has recently finished oral antibiotics for the last 2 days. The digit has been increasingly painful, edematous, erythematous. Currently takes hydrochlorothiazide to control hypertension. Remainder medical history is unremarkable. So just scanning it again real quick. 43-year-old male, left fifth digit. Okay, so imaging. Let's get X-ray foot, X-ray ankle, CT foot, MRI foot, just because we can. Yeah, sorry, radiograph foot. Yeah.
Oof. They gave you both.
Nice.
And then you see we have 10. They give us 10. Oh.
Yeah, hit the CT. Should we get ankle as well?
Sure.
CT, MRI, radiograph reviews.
Radiograph ankle 3 views not available. Sure. Okay. How about bone scan?
Sure, let's do it.
Oh, they gave us something on the bone scan. Okay.
Yeah, there you go. Okay.
Interesting, man. They're giving us a lot.
That's crazy. So I'm seeing this now. I mean, we could get more, I guess.
I'm gonna get ultrasound. Okay.
Ultrasound.
Okay, we still have one more. Okay, so we got a lot of things. Okay, okay. So we have a lot of to decipher here. We're on to 12 minutes. Okay. 43 presents post-op shoe, painful, swollen left digit. Here's history. Okay, he stubbed it. Okay, he stubbed it 2 weeks ago
after being posted.
Okay, so there's trauma. There's trauma to it. Okay.
So sorry, go ahead.
And he was discharged 10 days ago. So he stubbed it so he stubbed it, then he went into the hospital, then he had sepsis, so bacteria in the blood from sinusitis, and finish or antibiotics for the wow.
So
Wow.
my toes all messed up. Yeah.
And
So I go over to labs.
so here's the fifth toe,
Yeah.
right?
So I mean, I'm looking at that already. I'm thinking obviously infection just by looking at it. I mean, and then he looks like he really has a fracture there.
Wow.
Uh,
And he has a fracture, right?
yeah.
Then it's with this whole history is like, okay, interesting. Okay. Oh, because infection is still right. I mean, so this is a T1 or T2 image, everybody. T1 or T2? I mean, is this T1 or T2?
Two.
Two. Okay, good. T2. Bone should be dark.
Mm-hmm.
This is dark. The fifth toe is dark. I just see, right? I mean,
Yeah, it's not that bad. Yeah.
not that bad. Okay, but they only give us one image. Okay, all right, one image.
So maybe we go over to labs.
Labs. Okay, yeah. Sorry, let's do labs. What do you want to do?
CBC, BMP. Well, I guess we have to do each one individual, right? So if you type in serum, yeah, that one, and then serum, and just go down the entire list of. So I would do, calcium chloride. I guess it's not necessarily, but yeah, I guess we can jump to that.
They're both elevated, and he's got a little leukocytosis. Interesting.
We check the.
What about electrolytes or I guess
You have to do each one. So sodium, potassium, whatever you
No,
want.
I know. Okay, just because he's got hypertension and all that stuff. Okay. Very. Oh, you guys got me.
Do you care about his LDH?
Yeah, but so we have 20 labs. In every infection case, you must do the first thing, please, blood culture.
Mm-hmm.
The first thing before white count. Okay? In every infection case, the first thing you do in physical exam, vitals. First thing, okay? Oral temperature or body temperature, and then blood pressure. Every time you have to write that down. Very important in every infection case, and that's what they look for. Okay, so it's not available. All right, no problem. What about like aspiration? No, that's more procedures. Okay. I did the joint aspiration. Let's do A1C normal. Let's do. Anybody else think of something? Oh, gram stain negative. What else do we want to get?
Lactate dehydrogenase?
To make sure he's not still septic, huh?
Right.
Anything else?
Sodium, we got.
Yep, we got everything else. So, is there an infection or no? There's for sure an infection.
He's got the ESR and the CRP elevated in the left shift, so all those are pointing at infection.
Yeah. There's
Even though they gave you the 11,000 borderline.
Yeah. Okay. And there's a fracture. There's an infection and a fracture. And the Certex scan.
Increased uptake, 5th digit.
What does this tell you?
There's bone turnover there, concerning for infection, even though your stains were all negative.
What about this? Would there be
Yes.
bone turnover from a fracture?
For sure.
Exactly. So and the MRI is actually
more soft tissue.
More soft tissue. Okay. All right. Anything else you want to order here? think about what you want to do physical exam now.
Nice. Is bone culture also an option in the labs? I don't remember. No.
I think that's a diagnostic procedure. I think this is more of a diagnostic procedure, but I don't think we can go there.
Yeah, I think have to go.
Oh, can we go there? Oh, I guess we can. I think we can.
Yeah. Bone culture as well. So it's all pointing towards a fracture as opposed to pathologic fracture necessarily, or a septic joint.
I even tapped it. Look at this. Some cellular aspirate, no fluid. Okay. Okay. So what's the diagnosis here? We can pick a diagnosis before even going to the physical exam. Okay. So ready for the physical exam is going to be 10 things.
So vitals, like you said.
Yep.
So body temperature,
So
blood
but
pressure.
yeah, but look how they don't take it from you, right? They just say yeah. So
heart rate.
okay. In every infection case, you have to also think about
Lymph nodes.
Respiratory rate.
we also have to palpate the toe, right?
Range of motion of the toe. I think it just says interphalangeal joint. Or metatarsal phalangeal joint.
I didn't check sensation. Anybody else? There's one more thing I have to check, or we can check. Pretty much it, right?
Yeah, I guess you could palpate the lesser MPJ or range of motion of lesser MPJ just so you click all 10. So now you know it's localized, not to that.
Yeah, yeah. So it's not a bone infection. There's definitely, there's definitely there's definitely cellulitis. I mean, you can see, right? See the different color? You see that?
Sure.
And swelling and white count. So, but even the bone pathology, it won't be positive for some time. But a bone culture, if there was an infection, it should grow something, even though the patient was on antibiotics before. But interesting. Any other diagnostic procedures we want to do? Not much, right?
No.
Okay. All right. What's our diagnosis here?
Fracture of the proximal phalanx, 5th digit. Cellulitis. Would you go with just for a third one, just cellulitis, like the general cellulitis? I know that was an option.
Yeah. Yeah.
Do you always fill out as many options as you can? So like if it's asked for 3, make sure to put 3.
Yeah. You're not going to get points off for putting some. You need to get what they are looking for. I'll show you the answer. The answers now. Okay. So what are we going to treat with?
Plate, oral antibiotics. You can pin it.
Does it need it?
Splint it.
Yeah. Splinting, oral antibiotics.
I think
There's
weight
10.
bearing. I think weight bearing is also an option. So like limited weight bearing or non-weight bearing. Protective. Partial.
Partial, sure. And then what about
There it is. Intravenous.
yeah, because if he's not getting better with oral, I'd do intravenous. Okay. I'm comfortable with those. Yeah.
Yep. You got one more section.
There's 10, so I can, yeah, there's one more section. So we're going to go diagnosis times 2. Patient returns 6 months later with no erythema, no open wound. Where's the UV? Okay. What's that? There's no erythema.
AVN. Non-union AVN. Fracture non-union.
Okay. All right, let's see. Okay, very important. Ready? Everyone's got to focus here. So, this is giving you detailed explanation of what they're looking for. Everyone can see my screen, right? Everyone sees this fine?
Yep.
Okay, so here's the stem, here's the physical exam. So what they're looking for is any one of the following. So all you have to get is one of these. Range of motion, interphalangeal joint, which we picked. Fifth toe exam. I don't know if we did fifth toe exam. I did. I think we did palpate fifth toe.
We also did range of motion though of interphalangeal joint, right?
Yep. Yep, we did that. Yep. They're looking for soft tissue crepitus in every infection. They're looking for soft tissue crepitus to rule out like an emphysema type of, obviously emphysema type of soft tissue infection. It's not just palpate. You want to type in soft tissue crepitus for an infection, especially around the wound. Always. So that's it. That's what they're looking for. The whole physical exam. They give you 10 options, 10 things. You just have to get one of these. Isn't that crazy? So they're not even looking for palpate pulses. They're not concerned about that. And a 43-year-old with, whatever. I mean, I would still do it in every case, just palpate pulses and a nerve exam, just like a light touch. That's just, I do it so, not to miss anything, but they're only looking for one of these. That's what they're grading based on. Labs, blood culture is the only thing they're looking for. Imaging, they're looking for an MRI. We ordered the world, but they're just looking for an MRI. And I don't know if an MRI is actually the best test to order in an acute fracture setting like this, but I mean, certainly you can order it and just see where the hyperintense bone is. Is it around the fracture, or is it more? Does it extend beyond the margins? Okay, and then but you need a good radiologist. So you got to sit and look at it yourself. Diagnosis: any one of the following. So abscess, cellulitis, we got that. Soft tissue infection, okay. Abscess, soft tissue infection, fifth toe, okay. So abscess, they want soft tissue infection, cellulitis, and I wouldn't say it's an abscess because, well, we tried to tap it, I guess, and there was nothing there. I did aspiration, and then so diagnosis. So this soft tissue infection and the fracture, they want both. Treatment, oral antibiotics, or IV, but they just want one. So this was a slam dunk case here. They just want one of them. Okay. And then diagnosis 2 is AVM. Yep, AVM. Okay. Let's do case number 2.
All right. Let's see. 47-year-old male presents 5 days. Status post resection of first metatarsal cuneiform dorsal exostosis of his left foot. The patient states that over the last 48 hours, his foot has become progressively more painful. He states that he has had fevers and chills. The rest of the medical history is unremarkable. He takes no medication. He is severely allergic to penicillin. So you said start off with imaging. So we get the x-rays, left foot. We can get a CT, MRI. Oh, gas. Okay. Do we have like a lower extremity CT? Make sure it's not going up. Yeah, or X-ray there. Okay. X-ray ankle maybe. Nice.
Anybody else want to order anything? We have one more thing to order. This picture is so unclear. I can't see anything, but there's gas in the soft tissue, so we know this soft tissue, significant soft tissue infection, post-op infection. The Sirtex scan is increased uptake in the first TMT, which could be from post-op, but there's likely a direct extension, osteomyelitis. He's 5 days post, so yeah, this is likely a contaminant from surgery. Okay. All right, where we any other tests we want to order? I mean,
We can get a venous duplex. Make sure it doesn't have.
you worried about that?
Not really, but
Just because of the timeline, though, I think it makes sense.
Yeah. Oh wow.
Set rate, CRP.
lactic acid.
Is there a wound culture? Bone culture? Oh, wound probe.
Any other labs we want to order? Pretty much good on labs, right?
Yeah.
All right. So this is another infection case. So
Crepitus.
yep. So, but this is pretty septic. So let's go with start with the initial, right? Oh yeah, this guy's septic. This guy needs to go to the ICU. Look at this. Okay. So non-palpable, which we already, we got the, crepitus.
Passive range of motion.
Wound probe or wound examination. Not applicable. Okay.
First ray, maybe? Oh.
Anything else?
Is there like something like tenderness to palpation or anything like that?
How that is gonna help us? Like just to palpate foot. You already said
Yeah.
splinting. Yeah, I already said splinting though, so I don't know. Within normal limits. Light touch.
Is wound odor an option? Smells good.
Good job. Yeah, this is important for antibiotic choice, right? Okay, so we maxed out, right? We maxed these out, and pretty much you're good with these. I mean,
Do you care about a bun?
about a what?
Blood, urea, nitrogen.
Sure. We have 20, so you can get the whole world if you want. Check out his everything.
What's his hematocrit? Do we need to transfuse him?
It's a good point. Let's do that.
Can we do A1C?
Did I do an A1C on him?
It doesn't say he was diabetic anywhere, did it?
Yeah, no.
No.
But still, I mean, in this pending joint culture, joint
Fluid
fluid.
gram stain, yeah,
Oh
negative.
wow.
Yeah.
Okay. All right. Diagnostic procedures, we maxed those out. Bone culture is pending. Bone biopsy is pending. But with this, we can. The gram stain was negative, so I don't know. Okay. So, what's the diagnosis?
Gas gangrene.
Septicemia.
Sure. Sepsis for sure.
Uh-huh.
Gas or soft tissue emphysema. There was a gas option, I think.
Thing is, I want to put osteomyelitis as one diagnosis. Don't you agree?
Yeah, for sure. You have. Oh, what else did you want to put for your third? For your.
Postoperative infection.
Okay, understood.
Uh,
Direct extension.
Yeah.
Is there gas on that MRI, or we can't really see?
We can't really see. I can't see stuff. I want to just do this. I want to do this. I'm more comfortable with this because gas gangrene is usually Clostridium or something,
Should show up on a gram stain.
anaerobic. Yeah, and there's no order. You know what I'm saying?
Yeah. Yep.
I definitely want to see this, but let's see what they say. He's
What
definitely
about the fact they mentioned it on the X-ray? They literally said gas in the foot.
yeah. Gas in soft tissue, yeah. So what can cause gas in the soft tissue in 5 days post-op?
You're still being open from the surgical site.
Exactly.
Yeah.
You have radiographs? You ever see a little bit of gas in a post-op bite?
Yeah.
Or ankle? Normal, right? I mean, it's not infection, it's just, the
True.
layered closure of the thing. So I think that's why, because 5 days is way too early to develop, because usually a gas gangrene, usually that foot's been sitting there for a few weeks and festering, so I think 5 days is way too soon for me to say this is gas gangrene. I mean, it's definitely look. I mean, all the compartments are tense. This is a multi-compartment abscess for sure. But gas in the soft tissue doesn't necessarily mean gas gangrene. Does that make sense? Because gas gangrene is an anaerobic clostridial type of infection. It's a gas forming infection. 5 days is not enough time for that type of process to even though they say gas in gas in the soft tissue, it doesn't necessarily mean there's that. Okay, so we're gonna go with definitely sepsis, definitely, or most likely osteomyelitis, direct extension, and post-op infection for sure. We're gonna do that. Or how are we gonna treat? We have 10 options.
Incision and
IV
drainage.
antibodies.
Well, where are we gonna do all that, right? We gotta get him to
Yep.
get him to the hospital, admit him. They definitely want to see this
Mhm.
in an open fracture, in a tongue type fracture of the calcaneus. They want to see this tongue type, okay? Or any fracture that's tenting the skin that needs to go. Anything that's urgent, anything that cannot wait, like 24 to 48 hours, you need to do this. You need to have this in. So admit to the hospital, okay. And we're gonna do
IV antibiotics.
yep, bone culture, antibiotics, intravenous. We're gonna resect probably some bone. So I'll probably do this. Incision and drainage with debridement.
Wound culture.
Resection, bone. Bone culture. Yeah, I did that. Bone culture. Yep.
Wound culture.
Oh, wound. Yes, yes. Sorry. This is in the midfoot. So I would say
Back it open.
depending on how much bone I have to remove, I'll mini rail this. You know, I'll put a mini rail. Maybe, or maybe just a splint, but you can also add. So these are for sure we're gonna need. Maybe wound vac. So I know we're talking a lot about this, but you can see the time is definitely an issue here with these tests. So, but hopefully we got all of them. So let's see. So, any one of the following to evaluate for systemic involvement. So, you know, we put vital signs, so they gave us all of the above, so that's good. And any one of the following: soft tissue crepitus, palpate wound. Okay, and lymph nodes. So they wanted all three. We got all three. Okay. Nothing here says palpate pulses.
Mm-hmm.
And it's crazy because I almost, it's like if I get a question from someone that says, "Oh, well, I'm not gonna palpate pulses," then you're not wrong. I can't. You know, I can't justify that. What they're looking for is specific, focused physical exam in every case. So, and this is from their grading. So this is not. I mean, this is the real deal. This is ABFAS. So, okay. Labs, blood culture for sure. Okay. Like I said, every time it's vital signs and blood culture, and then we'll do the other stuff. Those are the most important. And then any one of the following, so C-reactive protein and sed rate. Sometimes I think ordering just one of those is enough because it makes it, you're telling the exam that you know that you're going to trend inflammatory markers. So maybe it'll save you. But with labs, we have 20, so I don't think it's, physical exam is the most important. Physical exam because you only have 10. So sometimes you want to definitely get as much information to guide your physical exam from the imaging and from the diagnostic procedures and from the labs. So you definitely want to do that because physical exam is by far the hardest because it's only 10 things. And there's a lot of things typically we do in a standard physical exam. Imaging, x-rays, of course, we're going to start with x-rays and any one of the following, the Certex scan. Okay, well, that's a label scan. Okay. And these are, I've never seen these so specific. They're very sensitive, but they're not specific. MRI is probably more specific, to be honest. Okay. So they want osteomyelitis. Even though I think one of the culture, I think a culture was negative or something, or oh no, they were both pending. They were both pending. So they want osteomyelitis for sure. Direct extension from the wound. Because there's no history of the patient being sick or having a dental cleaning or something like that, or having UTI. So it's direct extension osteomyelitis because it's from the wound, it's from the surgical insult. And and of course, cellulitis or an abscess, and then postoperative infection. But they just one of these is fine. So bone component and soft tissue component. Sometimes they can be sticklers with because it's post-op infection. It's got to be post-op infection, and that's why I said I want to do a post-op infection, because I've had these cases like that before. So treatment, wound culture, gram stain, any one of the following, okay, and then any one of the following: pack wound open, admit to the hospital. Oh wow, that's it. Okay. So of course, I still defend my urgent treatment, like urgent emergent management, because that's important.
I think you brought up a great point, though, Doc. I think I would have been more inclined to say gas gangrene because of all the the high white count and everything else. But the fact it was post-op, seeing gas in the tissues, you shouldn't jump to that answer.
Yeah, 100%. I mean, it's only 5 days. If it was like 3 weeks and this patient's like sitting in a nursing home, or they have neuropathy, or they couldn't get to the hospital, or they were taking pain meds, and just masking the pain, then I would say it's more likely, especially if there was order. That was a good job on you picked the order of the wound. So, all right. It's 8:40. I know everyone's getting tired. Should we do one more case, or call it a night here?
Do you have any more of those multiple choice? Maybe bang out a couple of those and call it a
I
night?
know. Yeah. I have to finish this because I can't. I don't think I can stop midway. All
You
right.
could do one more case.
You want to do one more case?
Yeah, but I would like to tag team with Cassie, if that's fine, to get the females a chance.
Yeah. I mean, we don't have. Yeah. I mean, it's a good thing, for sure. Let's do another game, and then if you find this helpful, we can do this. If you like this, this is typically the way I do it. If you find this helpful, I'm willing to do this more often. So maybe, I don't know, once a month or something like that, or once every other month. Okay, let's do another case then.
Cassie, you ready?
You ready?
Yeah, let's go.
Okay. So I have a 32-year-old East Indian male presents with a 16-year history of an enlarged mass on his left foot and ankle. He has difficulty wearing shoes and experiences pain with every step he takes. He has no allergies and is not taking medications. Okay.
This looks like along the interesting.
Yeah.
Do you think we should order a blood pressure or capillary refill test?
Oh boy. Let's get some images first.
Yep, exactly. Let's do it.
If you want to get foot x-rays. Okay. Awesome.
X-ray. Yeah. We'll do CT.
Yep.
Um,
Okay. Can we look at those MRI images?
Looks like a bunch of tumors along the nerve.
how do you know it's along the nerve?
Isn't it because never mind.
Oh, it could be along any of the PT as
It
well.
could be along the tibial nerve as well, since it's on the medial side.
Yeah. Interesting. So this is a T1 image, and they're hypo intense on T1, but hyper intense on T2. Okay, well defined along the medial side, but really posteriorly. Okay, all right. Any other imaging? Want to do Any other imaging somebody want to order?
Should we do a CT scan?
I ordered that already.
Oh, yeah.
Of ankle.
Oh,
Ankle.
Yeah, I just saw that.
We can. Yep, we can. Not available. Not available. Okay.
I feel like we're good to move on.
I did a PET scan too. Not available.
That's smart looking for cancer.
I mean, should we look at markers?
Let's do the imaging. We only have 2 more.
Why not scroll up? There was testing the ankle, radiograph ankle, 3 views. Man, why can't I see these on the side?
So let me see here. You want to do just a regular radiograph? I think because we already did the ankle MRI, so I think it's okay. Is there a way we can test?
Should we check bone density because of how it's presenting? No, it was an option up there in the selection panel.
Yeah, I think the bone looks okay. I think it's mostly, you know, I don't really see. I want to further explore the soft tissue a little bit. Further explore the soft tissue. Is there any nerve test that we can do here potentially, or no? Okay.
And that'll be that one. You have to check the aversion, but then you will have to do a physical exam on that.
Yeah. Yeah. Okay. Let's do the ankle X-ray. Good job. They wanted it. They wanted the ankle X-ray. Good job. So even though we ordered the ankle, we see the ankle MRI, they wanted an ankle X-ray. Soft tissue density increased medially, plantarly, posteriorly, no osseous involvement. Good job. Always check the X-ray. So we ordered a whole bunch of stuff, and we were gonna miss this. No osseous involvement. So that's good to know. Okay. Okay.
Can we do a bone by
Let's see.
Can you scroll down, please? Can you do nerve biopsy? No. Nerve conduction velocity. Can we check that? Can we also please check? Can you scroll up, please? Should we do biopsy needles since there was some foreign substance? Biopsy.
Can
I
we
want
also
to
do the aspirate, the needle aspirate?
No aspirate obtained. How do you miss this aspirate? If there was something that was going to come out, you would aspirate it. Kind of weird. Okay.
Should we do muscle biopsy? Just because of the invasion?
Yeah, we could. Look, diagnostic nerve block proximately results in a significant reduction of the patient's pain. How about an EMG?
That's fair.
I think that's a good idea.
Within normal limits. Oof, okay. So, larging mass, difficulty walking, experience pain with every step he takes.
Proximal tibial. So if you do a proximal tibial nerve block.
So it's definitely telling us that there's the tibial nerve is definitely involved. There's definitely some involvement, either encroachment or Maybe it's a tumor coming from the nerve.
Should we try tarsal-metatarsal joint? Diagnostic block?
Oh, I'm sorry, we ran out. There's only
Oh.
5.
Okay,
Yeah.
perfect. Let's go.
Okay. So imaging, we pretty much rocked all those out. Okay. All right. Let's 7 minutes left. Focus based on diagnostic procedures and imaging. Focus on how we're going to take the physical exam. So what's the first thing we're going to do?
Palpation. Yeah.
Palpate mass. Okay. Firm, semi-mobile, painful to palpation.
Check the pulse. Dorsalis pedis pulse, maybe? Or popliteal.
They're both normal. When I do pedal pulse, if it says be more specific, then I do those. But if I do pedal pulse and they're both normal, they're both that means they're both normal.
Does that include the posterior tibial pulse as well? Or?
Yes.
Yeah. Typically, they're both normal.
Okay.
I'll do it. Just but typically,
Yeah.
if you do palpate pulses, they're both normal. Typically.
Is there a transilluminate
Good job.
or maybe mass exam or something?
All right, give others a chance.
Yeah. Good job. Good job. There's we should have done it. We should have done a transilluminate, and nerve conduction velocity and EMG, they go hand in hand like ESR and CRP. So in my mind, if one of them is normal, maybe I shouldn't have ordered the other one. Perhaps. But okay. Anyway, I mean, if you dissect every case like this, you're gonna pass with flying colors. Most people don't do this. Okay. Go back to the physical exam. We picked 3 and we need 7 more. So who wants to palpate lymph? Because any mass or any infection, we should palpate lymph nodes, right? So they're normal. Okay. Who wants to do?
How about a deep tendon reflex? Just to see how far it affects.
Normal.
Okay.
How about Tennell's?
I don't think Tennell. Oh.
The reason why I picked Tennell's is look, nerve block. It's telling me that there's nerve. The nerve is involved. The nerve is involved. Right.
Usually for cancers, wouldn't we see the skin, the consistency of the skin also?
Sure.
Okay.
It's a good job. That's a really good job. Consistency of the skin is very important because semi-mobile, and it's not adherent to the skin. So something that would adhere to the skin would be like a fibrolipoma or something, something a little more superficial. But this is something deep. This is something a little bit deeper. Coming from the deeper. Well, it's not coming from the bone. We know that because there's no periosteal reaction, no bone involvement. They didn't give us an X-ray, but they told us that. They told us that with the imaging. They told us no bony involvement, so you can put bony involvement for sure out of the way.
How about some muscle testing?
Sure. Good job. Muscle. I'm thinking it's the posterior tibial and flexor. Right?
Why the flexor? Why couldn't it be extensor?
Well,
Location,
I don't think there's any extensor involvement.
anatomy.
Right? You know what I'm saying? Like this is extensors.
Oh, okay, yeah.
I think the flexors may be more, or could be more, maybe more involved, but they're normal. I want to do light touch. Wow. Okay.
Can we go back to the menu again?
Yeah, we're done. We
Oh, perfect.
we're done. We have 2 minutes. Okay. Diagnostic procedure. So So what is this?
Cancer.
It's a, oh, the diagnosis is neuromyeloma.
If it's a lymoma, then it is considered cancerous.
Yeah, proceed with treatment.
Removal.
Neuromyeloma. Yeah,
You would
Um,
just have to do removal at that point.
nerve.
Excision of mass with nerve preservation.
Yeah,
Yeah.
if possible. Yeah.
Because if it's a myoma, you could definitely remove it.
Yep. Okay. Let's go here. Let's see what we have. So physical exam, they wanted Tenels. I think we picked Tenels, right?
I hate y'all.
Yep, we picked.
So
Yep,
much.
we-
Don't help me on this. I literally have to call this my own. You know what? I'm proud of myself. How much I did on my
Do you
own.
mind muting yourself there, Danny?
Leiomyoma.
And then imaging, they wanted MRI. They wanted MRI. And we had the MRI, obviously. Okay. So where is this? Okay. Incisional biopsy, needle biopsy, and then one of these. They wanted one of these. And then excision of mass with nerve preservation. Okay. Yeah, we got it. So pretty much there's going to be 1, 2, 3, 4, 5. 5 main points on this exam. And I think, you know, we talked about pretty much everything. And so you can see how it's not so complicated. Some of these are, you know, of course, you know, I think the first one was the most complicated.
What was the treatment again for that last one?
Oh, just removal of resection of mass with nerve preservation or excision of nerve sheath tumor. So either one of those. And it's confirmed that it's a nerve tumor based on the nerve block and the Tenel sign, or at least a nerve sheath tumor. But or it's not really confirmed. They gave it to you. They told you that's the diagnosis. How do you treat? So this one is just really whether you know how to treat it or not. But to get to it, we did all the right things. I think we followed up the nerve block by a Tenel sign, which is very important because you want to confirm, because they don't necessarily, the way this goes is the expectation is to do the physical exam first, but they allow you to do some diagnostic procedures and imaging first. Just like if you were in a clinic setting where you say, oh, every patient with this comes in and I order A, B, and C. So, all right, very good. So yeah, I think it's time up here, but thanks everyone for sticking around. And then we will, if this was helpful, I'm more than happy to do more of these. There's a lot more cases that we could have done and whatnot.
Thank you very much, Doc, for your time. We really appreciate it.
Thank you so much. Appreciate it.
Thank you so
Thank you
much.
very much.
For sure.
Jazakallah khairan, man. This was very helpful for myself, especially just kind of being reacquainted with this stuff, and you know, for me to help other people too. So thank you so much for your time. This is going to be recorded and shared, I'm sure, useful for a lot of other people, inshallah.
Okay, great. All right. Thank you. And yeah, I look forward to doing these. We'll be in touch.